Dr. Jackie Boggs. I'm a veterinarian at Zoetis, and it's my distinct honor to get to introduce today Dr. Dwyer. Many of you know her as a past president of AAEP. She has a general practice in Rochester, New York, Genesee Valley Equine. She's had a very long interest through her career in equine ophthalmology and particularly ERU. She's an honorary member of the American College of Veterinary Ophthalmologists, and she's here today to share a little bit about the disease with us. So thank you all for coming. I know it's bright and early, but we really are thrilled to have you here. So without further ado.
I'm very honored to have the opportunity to give this lecture because this is a subject that is, I think, a little bit ignored in our training, very, very much misunderstood. Not a month goes by that I don't get a call from a practitioner who is having a problem, whether it's lepto-related or not, with uveitis, and they would like me to answer their questions in 5 minutes. I can't do that. This is a complicated disease, and it depends on a real thorough understanding of anatomy and physiology. And I've told this tale many, many times to students in the truck or to practitioners who've come to visit, and I'm very glad for the opportunity to share it with you because I think I'm going to send you home with some understanding of eye disease that will help you diagnose this disease, understand this disease, and go forward to help your patients and perhaps save sight. So this lecture is going to discuss ERU and the lepto link, and there's no way you can do it without reviewing anatomy. So that's what we're going to start with. And then we're going to talk about what uveitis is, and what's equine recurrent uveitis, and then what's leptospiral-associated uveitis. And then I'm going to present decades of practice data. I've been in practice for 33 years, and I've been following my patients for that period of time. And that's valuable because I know what happens to them over the long run. The pathophysiology, which is very complex. And then we're going to talk a little bit about the ravages of leptospiral-associated uveitis. But before we do anything, we've got to start with anatomy and physiology. So what I've done here is I've cherry-picked some of the best and most famous medical illustrations in the literature to just kind of dial back for a minute. Remember how complicated the eye is and how beautiful it is that in its function. But any place you slice through the liver, you're going to find the same things. A little bit different blood vasculature, but the same types of cells. Anywhere you slice through the eye, you're going to find something different. And the eye has evolved for really just one purpose: to be transparent along its central axis, to allow light energy to get through to its computer, to the retina. And that's a tall order. And how the eye has done that is really a magnificent story. You probably learned in school about the 3 layers of the eye, and you memorized them, and you could regurgitate them back. They are critical to understanding this disease. So we're going to see this picture over and over again. The 3 tunics, I like to think of them kind of like Russian dolls because they're nested in amongst themselves. And in a minute, you'll see why I also refer to them just like a pita sandwich. The outer fibrous tunic, the cornea, is the upper layers. And have you ever thought about how amazing it is that the cornea is transparent? Try to think of anything else in your body that's completely transparent. And yet it has a very complex organization of different layers. The outer layer is epithelium, like epithelium you see everywhere. The middle layer is stroma, which is like pieces of bread stacked on top of each other. And the very bottom layer, the endothelium, is one of the key reasons that the cornea stays transparent. I call the endothelium like the defroster of the eye because it is constantly pulling water out of that cornea. And if it starts dysfunctioning, that cornea turns blue just like your windshield does on a frosty morning. Now we come to the business layer that we're going to talk about today, the uvea. It's the red layer on this cartoon. It's the major blood supply. And why is the blood supply concentrated here? Because you couldn't have a transparent structure with blood vessels all over it. Yes, blood vessels grow onto the cornea during disease, but they're not there during health. So the eye has evolved to keep all the blood vessels in this one beautiful but complicated layer. Why is it called the uvea? Well, that traces back to the Greek word for uva, which means grape. And this is why I like my sandwich analogy. Nobody likes to eat a sandwich that doesn't have mayonnaise and a tomato in it. The uvea is the tomato of that sandwich. And the other parts are the iris and the ciliary body and the choroid. The visible part is the iris. We all know that. But all of this nourishes the entire eye. The iris opens and closes like a camera. We all know that. Kind of an interesting thing is there's no epithelium on the front of the iris, but there's 2 layers of epithelium on the back of the iris. And that little pesky thing, the corpora nigrans, is actually a little bit of that epithelium that's crawled over from the back of the iris onto the front to form that little bubble or baseball cap. Now we come to my favorite part, the ciliary body. And we all learn this cartoon here, okay? And you have to regurgitate in your quizzes that that's the ciliary body, and it just looks like a little bump, and you don't think about it very much. But actually, it's pleated. It's an enormous amount of surface area. Just think of the demands on the eye. Huge oxygen tension there that has to come from somewhere. So how does it do it? It's formed kind of like a mushroom on the inside and pleated like that. And here's the iris here, and there's the ciliary body all the way around the outside. So don't think of it just in cross-section. I want you to think of it in 3 dimensions, because that's going to be important later on. The ciliary body does a lot of things. It makes aqueous humor, which nourishes the inside of the eyes, part of why the cornea stays transparent. And it holds up the lens. I like to think of it like springs on a trampoline. And it helps lens accommodation, and much more of an important thing in us than in our horses, but still, that's one more thing that it does. I call the ciliary body the body's multitasker. And it's really amazing. So keep these things in mind. The trampoline springs to hold up the lens. Think of it like a soaker hose. It is constantly bleeding little bits of aqueous into the anterior chamber, and the aqueous stays there for about 90 minutes, circulates around, and goes out through the drainage angle. And if we're lucky, it functions like that through our whole life. But you interfere with one or more of those functions, and you have a disaster inside the eye. The remainder of the uvea, the choroid and the choriocapillaris, I like to think of that like the heat ducts that are up above this ceiling right here. They're delivering all that blood to the retina by being opposed right against it. The inner neurosensory tunic is the retina. That's the computer of the eye. It has a complex structure, and that structure is highly oxygen dependent. It needs a lot of nourishment. It needs everything that uvea can bring to it. And then we have other parts. The lens, which focuses light. And again, remember, it's held up by those zonular fibers that are coming off that pleated ciliary body. And again, it's transparent, and it's another miraculous tissue. And it's not transparent just by accident, or just by nature, like your windshield of your car. It's an active mechanism that keeps it transparent, and it can get cloudy just like the cornea can. The vitreous humor is a gel-like fluid that fills the posterior segment, and it actually has structure. It's not just a simple gel. And then we come to our physiology. And I'm not going to spend too much time on this, but I want to remind you all that the eye depends on the blood-ocular barrier, and this is a key concept. It's present in normal eyes at all the uveal boundaries and at the retinal blood vessels. And it keeps immune cells, cytokines, and antibodies out of the inner eye when you're healthy. It's complex. When I was in school, I thought of the blood-ocular barrier as just kind of like a piece of saran wrap. But it's really much more than that. It is a physical barrier, but also there's an active mechanism that's keeping all those immune cells out of the eye most of the time. And remember, all those incredible structures that are inside that barrier just going along, kind of working independently from the rest of the body. So normally, the inside of the eye is immune privileged. And this is a very famous case in human ophthalmology. This is a little boy who was gardening with his mother, and he sustained an ocular puncture into his cornea. And I think he kind of rubbed his eye for a little while, but his mother really just thought he was just malingering or something. And later, they noticed that something looked a little bit funny in the eye. This is a bean sprout that actually sprouted in his anterior chamber. It was warm, it was wet, it did what it was supposed to do. Because when that bean sprout went inside the eye, it it did not break the blood-ocular barrier. So the inside of the eye is foreign, but it's tolerated, but not in uveitis. So just what is uveitis? It starts as inflammation of the uvea, which is disruption of the blood-ocular barrier. And once that goes, all bets are off. Immune cells and cytokines gain access to the inside of the eye, partially by just physically leaking through where there used to be a tight junction, and probably also because some of those more active mechanisms are disrupted as well. Now, we've got a pretty full room here. Just statistically, at least a few of you or your children, and children, I'm emphasizing children because this disease hits young people, are going to have uveitis sometime in your life. It's the third leading cause of human blindness. It looks in a person just like it looks in a horse. Terrible. And it's horribly painful. And if you get it, you will go to a specialist and they will try to rule out 100 different diseases. And even so, 30% of the time, they're not going to figure out what's wrong with you. They're just going to say idiopathic, immune-mediated, blah, blah, blah. It starts as inflammation and it progresses to immune-mediated disease. Remember that. It starts as inflammation and it progresses to immune-mediated disease. And in the topic we're talking about today, it starts as infection and then progresses to inflammation and then progresses to immune-mediated disease. Immune tolerance is lost, and the T cells and mediators go into the eye, inside of the eye, inside the uveal barrier, and they go crazy because everything that's in there looks foreign. And inflammatory damage to multiple structures is just like dominoes. It can lead to blindness. But there are many, many roads that lead to blindness, and that's why uveitis looks so different in all the hundreds of horses that you see during your life. You might see that I kind of like analogies. I like cartoons. I like simple things. I don't have a complex mind. I think of autoimmunity like bullying. And just like the school bully can pick on one kid and then decide to pick on another kid and then recruit others and they become a gang, this can happen inside the eye too. And when bullying gets bad enough, somebody moves in to regulate it, and the same thing is happening in the eye. So this, I credit Brian Gilger for this little cartoon here. What's happening is a sensitized T lymphocyte is crossing the blood-ocular barrier, and not just 5 of them, but millions of them. And they're looking in and they're seeing all these targets, which are part of the retina. This is the retina down there. These are the common, very immunogenic antigens in the retina. And the red is the choroid. And they look and see these host proteins, and they're foreign, and they attack them. And you get your flare. But the good guys come in too. They say, come on, bullies, we've got to get you under control. So the regulatory cells come in, and they quiet things around, and things are okay for a while, until they're not. And this is another key concept. Just because a T cell has found one molecule, one antigen to react against, it's not going to just stay peaceful and react against that one. It's going to be like the bully in the schoolyard, and it's going to pick on its friends. And that's what happens. You get a phenomenon called epitope spreading, where the cells and the cytokines attack not only the original antigens, but molecules that are nearby. And over time, even though you have this yin-yang between the regulatory cells and the attacking cells, you get degeneration. And again, it's your dominoes, and eventually that may lead to blindness. And in my hands, I'm no miracle worker. I can observe this disease. I cannot control this disease. And over 50% of my patients have lost vision from it. So what is equine recurrent uveitis? It's the #1 cause of blindness in horses. Up to 1 to 2% of the equine population has vision-threatening ERU. We really don't know how many, but I do know from the database in my practice. And we're probably hovering around 1%. It's a little hard to get your hands on that, but that's probably realistic. Recurrent episodes of intraocular inflammation with periods of quiescence in between. It is immune-mediated, and there are many, many different triggers, just the way there are in people, where you would get tested for 100 different things, and 30% of the time they wouldn't be able to figure it out. And leptospirosis, by the way, can cause a problem in people, too. Acute ERU is pain, lacrimation, photophobia, and meiosis. I can't tell you the number of times practitioners have called me and they've described some problem in the eye, and I'll say, well, what did the pupil look like? And I'll hear this silence on the other end of the phone. If you do nothing else, look at the pupil, and because it's going to tell you a lot. Because what is the pupil? It is the border of the first part of the uvea. So it is really, it's telling you a lot. It can be unilateral, it can be bilateral. The cornea should be fluorescein negative, but sometimes it's not because it's a complicated disease and sometimes they've rubbed their eye and scratched it at the same time. The signs on the outside are conjunctival hyperemia, chemosis or cloudiness, tearing, blepharospasm, corneal edema, especially at the limbus. And usually it's very symmetrical edema at the limbus. And often it induces blood vessels to grow onto the cornea. On the inside, what's happening? You're getting flare in the aqueous. And if you get enough flare, it's like a snowstorm. It snows and it falls down and it makes a snowbank and it creates something called hypopyon, which is literally just a snowbank full of white blood cells. A muddy color to the iris if you're able to see it. Meiosis. Have I said that enough? Meiosis, meiosis, meiosis. A murky, vitreous, and often that gives a green or an orange tint to the fundus, and you just don't feel like you can focus on that fundus well. So when does acute uveitis become ERU? Well, there's a variety of things that can insult the eye. Horses are continuously inventing new ways to do that. They can have trauma. Bad corneal disease will always incite some uveitis. Not ERU, but it will incite some inflammation in the central tunic there. And infections. And of that, leptospirosis is the number one. You take an insult on a normal eye and you get your first episode. Maybe that's all you get, especially if it's something like a minor corneal ulcer that heals in a few weeks and never have another problem. But sometimes it crosses over to this horrible cascade where you get multiple recurrent episodes, or you get some kind of a slow, simmering, insidious problem where the eye just degenerates over time like it does in so many Appaloosas. The things that influence this, genetics, big role, the type of insult, and the environment. So now that you understand a little bit about uveitis, let's talk some now about leptospirosis. Because I think if you survey all the literature that's out there, and of course all the literature has come from all over the world, and we've got desert out here where you're probably not going to see a whole lot of leptospirosis. And where I live, you're going to see pictures of that in a little bit. You're going to see a lot. So the papers are coming from all different geographies. And I think if you sum them all up, you're going to get similar statistics to what I have found in my own practice, in that leptospirosis is going to play a role in probably around 60% of the cases, varying up or down depending on how much water is around where you live. Key facts of leptospirosis. I'm going to take you back. First, I took you back to anatomy and physiology, and now we're going to dial back to microbiology. If you're talking about a disease like tetanus or rabies, other things like that, you're talking about one organism that you can define very well and very easily immunologically. I think of leptospirosis like a huge family reunion with a ton of cousins, and they all kind of look alike, and you can't tell them apart until you see that, oh, that one has freckles, and that one's got a cast on its arm, and that one's blonde. And there's really only a few of those cousins that we're really worried about. In terms of the big classification of leptospirosis, the type that we're concerned with is Leptospira interrogans. And that's a picture of it, and it was called that because it looks kind of like a question mark. And that's the family, okay? We're going to talk about the cousins in a minute. The other non-pathogenic type of leptospirosis is called bireflexa, and I think that has coils on both ends. It's gram-negative, and the specificity, this is important, the specificity for the different serovars, what tells one cousin from the other, comes from molecules that are expressed on the outer surface membrane of this organism. Lipopolysaccharides and lipoproteins That's how they figured out what's what. And I might remind you that it is a spirochete, and there are a few other spirochetes that cause devastating disease in people and in animals. One is treponema, which causes syphilis, and I hear a lot about syphilis when I go to the human rounds because that can wreak havoc in the eye. And Lyme disease, and we all know what a puzzler that is. So it's not surprising that we've got some complex things going on with this other spirochetal disease. It's a huge problem here. Is the fellow that did my technical help in here? No, he's in another room. He came up to me and he said, oh, you're talking about leptospirosis. I'm from the Philippines. And he said, that's a terrible disease where I come from. And he was a medic too. So we talked about this a lot. And he was telling me how awful it is in his home island. And we tend to, we're in the developed world, and we tend to kind of not think about it very much. But the World Health Organization just convened a whole study section to try to quantify how much of a problem leptospirosis is in the world. And they think there is a possibility it may even be the world's #1 zoonosis. It's ubiquitous. It thrives wherever water is. It's highly endemic in tropical and subtropical regions. I don't come from one of those regions. But it's also seen in river valleys. And where do horses live? Most of them live somewhere around a river valley, at least in the east. Floods and high rainfall, he was talking about when the rainy season comes. He says that's when they see the cases. Increase your risk of transmission. And undeveloped countries have the highest number of human cases, partially because of the exposure risks. This group that just convened estimated that there's over 1 million human cases per year with somewhere around 60,000 deaths. So how about it in the USA? Well, it's now something that we're aware of if you have a dog. It's something that's part of the dog's vaccine protocol. And it seems to be on the rise, possibly because of changing weather patterns in this country, maybe because of more surveillance, I don't know. But the darker the colors, the more positive canine leptospiral seroreactivity. And this is from 2002 to 2004. So you can see it's an increasing problem. And this is some data that from University of Kentucky. They just took Coggin samples, a lot of them, from 29 states and from Ontario, Canada. And they found that 45% of them were positive for one or more of those cousins. Maybe not the bad boys, but the cousins. And Zoetis did a survey in 2014 of over 5,000 blood samples, and they found that 75% of them were positive on the seroreactivity for one of the cousins. What are the reservoir hosts? Well, you can see their pictures there, and I, for years, have been giving lectures just talking about deer and cattle and rats and occasionally pigs. But Dr. Brown here was the one who kind of enlightened me that raccoons have become more and more of a focus as a probable transmitter of this disease, and foxes and possums. And we all know that these animals are very ubiquitous around horses. These are reservoir hosts. So the organism is adapted to living in these creatures, and they will shed this organism in their urine for periods of time. Who are the incidental hosts? Well, probably some of us in this room. I mean, how many people here have necropsied foals that have been aborted that probably, or maybe definitively, have been leptospiral? I'd be pretty careful about your biosecurity if you're doing any kind of abortion handling, or dystocia or anything like that. We always are at risk there. Horses and dogs, and other species, but those are our primary ones. Generally, horses get exposed in pasture, and they get exposed by drinking water from their water source that's contaminated or grazing on grass that's contaminated with urine from a carrier species. How do they infect horses? Well, just remember, they look like a corkscrew. And what do you do when you put a corkscrew in a bottle of wine? You twist it until it bores right in, and they do exactly the same thing in the horse. So usually the horse just happens to get it in its mouth, and then the boring starts. But it can also happen on abraded skin. So if a horse is standing in pond water or crossing a creek or something like that, or you're doing the same thing, it can happen. It colonizes and it multiplies in the kidney. And once it's inside the body, we certainly know it can enter the eye, the placenta, and it can cross over to the fetus. And once it gets inside the fetus, it goes crazy in there too. It invades the lung, the liver, the kidney, and the heart. Many of these sites of invasion are immunologically privileged. So that's one of the reasons why all these spirochetal diseases, syphilis, Lyme disease, leptospirosis, can be so havoc-wreaking and so difficult to control and often difficult to diagnose. So, serum antibodies to the cousins. They're detectable in the serum at 4 to 8 days, and they persist for years. I'm almost convinced that they persist for life, but they definitely persist for years because I've surveyed a lot of horses many times over their life. And yeah, they go down over time, but they stick around. Infected horses may shed organisms in their urine because remember the little bugs get into the kidney, we think for about 4 to 5 months. So if you've got a case that you think might be leptospirosis or an abortion or something like that, you may want to run a PCR or fluorescent antibody test on urine that you gather from that individual. What are the signs of acute leptospirosis in horses? Most of the time, they're very mild. And that's why we very rarely diagnose it. I've only diagnosed it acutely a couple of times in my life, and my radar is up for it. The owner, if it's a broodmare out in the pasture, she's probably not going to be sick enough that anybody's going to notice that something is wrong. If it's a horse that's stabled, yeah, they might notice it's a little bit dull, a little bit listless. It may have a fever. If they take a white count, that's going to be off. If you're really looking hard, you may see some icterus, you may see anemia, you might see petechial hemorrhages, I never have, and you may see conjunctival hyperemia, but you're not going to see hot eye signs. So it's very rare that the diagnostics are done with the acute cases. Occasionally, it causes acute renal failure. And it also can present as placentitis, abortion, or stillbirth, but usually that's not acute. I think, I don't know what the time span is between infection to the abortion, but it's not days, I think, or it's not hours. It's probably weeks. So what is leptospiral-associated uveitis? This disease is really strange because the horse gets over the initial infection really quickly, like within a week probably. And then months later, there's a hot eye, just overnight. And you get all those signs I just talked about, including meiosis. And no matter whether you treat it or not, and I hope you treat it, but if you don't treat it, the signs are still going to settle down on their own. And then it's going to recur and recur and recur. And every time it recurs, remember the dominoes, you get more cumulative damage. It's going to harm more things inside of the eye because that ciliary body does so many things, and eventually you're going to have a blind horse much of the time, or a visually impaired horse, and we don't want either one of them. So now we talk about trying to detect whether it's there or not, figuring out if the cousins are in the body. So let's just think about 2 redheaded cousins that you can spot in this huge family reunion. And their names are Pomona and Grippo. And those are the bad boys. Those are the really bad bullies. And the Pomona is the most significant serovar in the United States and worldwide. It definitely has a high degree of cross-reactivity, especially with a serovar called interrogans. But usually what you will see is, if you're fairly close to the original infection, you'll see an elevated titer to, quite elevated titer to Pomona and a much lower titer to interrogans, and sometimes to other serovars too. Grippo typhosa we've always thought of as the European strain, but I'll tell you, I'm seeing more and more of it in my neck of the woods, and I think other people are around the country. Maybe 10% of the cases, I don't know. I mostly just do serum testing, and there's a lot of questioning about the value of serum testing because there have been horses that have had antibodies in their ocular fluid that do not have them in their serum. So that's weird. Maybe they got splashed in the eye and they just went right in there. I don't know. But I still do find, I'm a practitioner, and it's not a difficult thing to get ocular fluid from a horse, but it's a little bit of a dangerous thing to do in a barn. And I always will get ocular fluid if I enucleate an eye or euthanize a horse or something like that, but I tend not to do it on my live horses. But definitely ocular fluid is the gold standard. And so my research is based on serum MAT, and I've done thousands of samples, and I'm pretty confident that I can interpret most of them well. But do be aware that serum is not the whole story. But I definitely would urge you to do serum screening. And here's how you sample aqueous humor. Again, it's a simple thing. It's really not a terribly risky thing, but it's not going to fly if the gator comes around the corner or the dog runs into the stall or something like that when you're in the middle of doing this in my world. But if you can get ocular fluid from an enucleation or from a dead horse, you can do fluorescent antibody tests on it. You can do PCR. You can't culture, but a university can culture. But do be aware, it's very, very difficult to culture this bug. There's so many things that are just hard about this bug. It can take 6 months to culture it. And you can do immunohistochemistry. Here is the gold standard. This is Brian Gilger's table for how you should interpret your serum if you also have access to intraocular fluids, which many of us will on our enucleated or our euthanized horses. So now I want to just tell you a little story. Again, I said story hour about LAU in our upstate New York practice. This is a picture of my practice. So this is our world. And this is where we are. No, we cannot see the Empire State Building from our backyard. We're in Western New York. And our practice is named for a river, the Genesee River, which bisects our practice territory. That red is where we're located. And you can see that not only are we near a big river, we're near the Finger Lakes, which there's water everywhere. And it's wonderful horse country because it's great farmland. It's kind of economically depressed, so that means we have beautiful land, we have excellent competitions, every kind of horse activity you can imagine. But we also have lots and lots of water. Here's a picture of the Genesee River, which kind of winds around the Finger Lakes. It's beautiful wine country, and that is the Genesee River. And the incidence of blindness in our patients, not complete blindness, but being blind in one eye, if you follow them over their whole life, 33 years I've been doing it, is about 1%. That is actually unacceptable. Imagine if 1% of us were blind. And I started researching this way, way back in the 80s with Dr. Bill Rabune, my mentor and guru, who sadly passed on. And we started looking at Appaloosas. But pretty soon I thought, oh, this problem is bigger than just Appaloosas. I got to look at a little bit more of this. So I just started tabulating my data. And all of you in the room, we have treasure troves of data in our medical records. We have real world data, not in vitro data. We have the real thing. So I encourage you to do the same thing. And as I started to dig, and I had papers piled up everywhere, and I had all these confusing serovars, and I was trying to sort it out, and they had the Appaloosas in there too. I said, wait a minute, we've got a lot of farms with multiple cases. What's going on here? So I identified 8 farms, this is a long time ago, 20 years ago, that had multiple cases of leptospiral-associated ERU. And I plotted them on a map, and I think you can draw your own conclusions. They're all very close to our river or a tributary of the river. And many of them had other risk factors. They had deer, wildlife around them. They were beautiful farms, usually bordered by woodlands where the wildlife like to live. A lot of them had ponds for drinking water. Farm A, which is real close to our practice, had 2 abortions that I did do all the diagnostics, and I did confirm. One of them was like a $100,000 standard bred. I did confirm that they were leptospiral, and those mares did go on to become blind from ERU. And at Farm E, we had a rat infestation. I'll talk about Farm E later on. The common risk factors, I really just went down. And rats were not common in too many places, but I think the very worst farm that I saw was the farm with the rat infestation. So let's talk about one horse just as an example. His name is Willie, and dear Willie departed this world last year at age 37, but not from ERU. But I got to watch it for 21 years and see him multiple times a year for 21 years. In 1993, we had what was called the storm of the century. It was a snowstorm, but basically it dumped a lot of water on that territory. And it all had to melt, so we had flooding later on. It's the only time we've ever closed our practice, but we had so much snow we closed. And probably in the spring, when things started to happen, that's probably when these horses on this farm got exposed, because this was a farm, I think I had 4 or 5 horses here. December of 93, he had his first attack. March of 94, his second. Flare number 3, May of 94. Then he got a corneal ulcer. Important, because what do our clients like to do? Reach for the dexamethasone that's on the medicine shelf, right? But he had an ulcer because he was hurt. And he started to get calcium on his cornea. That's a nasty complication. And then in 95, he wasn't really having flares. He was just, every time I looked at him, he looked worse. We weren't really controlling anything. And I think this pond was the culprit. There's beautiful woodlands right next to it. Who knows if it was a raccoon or a deer or what, but all the risk factors were present here. Over 2.5 years, he went blind. We had a few more hot flares, and his acute blindness was caused by a detached retina. And then over time, we weren't done. Even though the eye wasn't really having flares, we had complications from this disease. This horse kept getting calcium on his cornea, which is a nasty problem, very difficult to deal with. I was this far away from enucleating him about 3 times, and the owner didn't want to do it, and finally things settled down. But, and eventually he became tisical, which is actually a good thing. That eye is less likely to get hurt if it's small. So he had, once it really settled down, it was a tisical eye, then he went on to having interocular hemorrhage several times and a few more corneal ulcers. So this disease probably cost this owner, I don't know, $5,000, even on a blind eye. But she didn't want to enucleate him, so we never did. But I did get to follow him for 21 years. He went blind in 30 months. He had 5 flares, multiple complications, and 25 vet visits in the first 30 months. So it's that kind of case that it keeps you up at night. You love your clients, you love your horses, and you're powerless to do very much about it. That really spurred me to take a little closer look at our data. And again, I'm trying to sort it out, trying to make buckets of who's who, and thinking about these 100 things that can make humans have uveitis and wondering how many we have with horses. And I knew lepto was a problem. I identified that 100 of 160 cases, I've probably got about 300 cases now, were leptospiral positive on their serum. And you can see that the level of the titers varied, but one of the reasons the level of the titers varied was that sometimes I would see a hot case, and sometimes I would see a horse that had had disease for years, so I don't think that's surprising. And then I also was seeing a subset of the Appaloosas that were worth isolating and analyzing. And just because Appaloosas live with the same risk factors that every other horse in the Genesee River Valley does, it did turn out that there was a group of Appaloosas that also were unfortunate enough to contract leptospirosis, and those were bad cases. I didn't find any gender predilection. Many of these cases were young, and that's when horses are in their prime, they're competing, they have their value, and they're probably out there playing around in their pasture, so they're increasing their risk profile. About half and half were unilateral versus bilateral, and I think that statistic still holds up. I'd much rather see a unilateral case. It's rare that a case that is unilateral for a couple of years goes and becomes bilateral. People always ask you that. The non-Appaloosas, I had a little bit more unilateral disease. And the Appaloosas, like I say, I think they're genetically programmed to do this, so it's not surprising that they had more bilateral cases. How many of them went blind? Well, of my seropositive buckets, 60%, 58%, nearly 60% were blind in at least one eye, observing them over an 11-year period. And some of these were old chronic cases, and some of these were hot cases that I followed along. We had a little better vision in the ones that were seronegative, but not much. So basically, once you've got uveitis diagnosed, recurrent uveitis or persistent, whatever the cause is, I think you better tell that owner that you've got about a 50-50 chance or even a 60-40 chance that you're going to lose vision in that eye. I did find that the Appaloosas who were unlucky enough to contract the disease had a terrible visual prognosis, 100% blind in one or more eyes. And if they didn't have leptospirosis, they still had a high rate of blindness. That was this group right here. But the ones that were seropositive and not Appaloosas were about 50-50. And I think those statistics still kind of hold up in the literature that's been published more recently. Our analysis did uncover the fact that Appaloosas are about 8 times more likely to have chronic uveitis than other breeds, and that has to do with genetics. And it's likely, I think of Lepto and an Appaloosa as a match on kerosene. So what's going on in these LAU eyes? This is what they look like on the outside. If you ever see one of these, this is a very classical lepto case. It tends to produce these radiating streaks that look like a sun inside. Not all of them, but some of them do. This is where it gets a little complicated. Here's a brief history. The first reports came from Germany, another place with lots of rivers. In the 50s, Dr. Roberts, the old polo coach from Cornell, studied outbreaks on 2 horse farms following a febrile illness. And he was he's a teacher at Cornell, but also an ambulatory clinician. So he had very good clinical data, very much like mine. And he published very good papers on it. Then in the 60s and 70s, Dr. Mortar at Purdue reproduced this disease with subcutaneous injection of live leptospiral bacteria. We call them the Purdue ponies, and I still have those slides. We need to do something with them one of these days. In the 80s and the 90s, University of Florida detected antibodies in the sera and the eye. The South American researchers were exploring molecular homology between lepto and the eye. And over the last 20 years or so, we've been accumulating more evidence of persistence of organisms in some of the cases, not all of the cases. Definitely evidence of DNA, more studies on molecular mimicry, anti-retinal seroreactivity, MHC expression, the pineal role, all kinds of things. So what is our theory of what happens? You have an initial trigger. You get exposure to the pathogenic leptospiral. The horse gets a little sick. Nobody even notices it, or doesn't think of it if they do see that they're sick. Somehow or another, that organism makes its way to the eye, and there is cross-reactivity between leptoantigens and self-antigens. Activated antigen-presenting cells in the uvea present these autoantigens to the adaptive immune system, and the eye has its own immune system. Target cells inside the eye recognize autoantigens, and they process these subcellular epitopes. The epitopes get presented to T cells, which trigger more autoantibodies, and then you get the epitope spreading, like I showed you in the cartoon that was a little bit earlier. You get amplification, you get reamplification, and perhaps there are stressors that then provoke some of these recurrences. Recurrence damages multiple components in the eye. Inflammatory change in all those components we talked about in the beginning, they can lead up to vision loss. Is it molecular mimicry or is it bystander reactivity? I'm not a researcher, I can't tell you, but I definitely can tell you that there are protein chains on the leptospira that are exactly homologous with proteins in the cornea and proteins in the retina. What is the evidence? Well, there's been quite a bit of evidence done in Kentucky and in South America about cross-reactivity with the cornea and lens proteins. And in the intraocular fluids, it's very interesting. There's been a lot of work just recently, some of which have been able to culture this organism, and some of which have found PCR, but not always. And there's this eternal debate. Are the organisms there or aren't they? Well, I almost think it doesn't matter, because by that time you've started this domino of the reactivity to the intraocular antigens, and whether the organisms are there or not, the horse has left the barn. Here's some evidence just in graph form. These are the red-headed cousins, okay? This is Grippo and Pomona there, and they've got very distinctive lipoproteins called LRU A and B on their ocular surface, and they've taken intraocular fluids from horses that have had these diseases, exposure, and this is hot reactivity to self-tissue right there. Remember I told you that rat barn? This was a lovely, lovely thoroughbred mare who was in that rat barn. I couldn't figure out why the owner kept it there, but she did. And obviously, we did not have a good outcome with this mare, but I've told her story many times. Her name was Eurosport. She went blind in about a year. Pretty sure she got it from the rats. And we took her apart at the University of Rochester. I was fortunate to work with an ocular immunologist there. And these are pictures, probably 20 years old. But look at this. Remember, I just said there are no lymphocytes in the normal eye. This is a lymphocyte army right there. And this is the ciliary body, okay? This is her optic nerve head. All those dark things are lymphocytes. This is her retina, which is detached, and that's her blind eye. And here is, anyone know what this is? That is a Peyer's patch, which we all have innately. And we've turned the ciliary body into the stroma below the gut, basically. And this is not just isolated. These are all over the eye. That Eurosport was 20 years ago. Here's a couple of recent cases where we've applied some modern technology to the cases. And they're two very different stories. This was an abused, neglected ex-racehorse thoroughbred who was on her last legs, literally, when I saw her. She had bilateral uveitis. Who knows what her history was? She had multiple other problems, starved, sick, and she was euthanized. She went through a stall because she was blind, and we took her eyes. This was a treasured pet she was 28 years old, she's still alive, and she developed that calcium problem. So I enucleated, fortunately she only was affected in one eye, and I enucleated her eye, but we had access now to our ocular fluids. And here's what we found. This is a classic C value here. The serum on both of them, I think both of them had a problem long ago, so the serum levels weren't too high. But look at these interocular levels, very high. Here's a normal ciliary body and iridocorneal angle. Here is Star, who was the abused and neglected racehorse, okay? And even without being able to see detail, you can see what a mess this eye is. This is why this disease is so hard to treat. Here is the treasured pet, okay? And she's got the same thing, even though she's had beautiful care her whole life. Both of these, this is, actually, this is a contrast between the two of them. But they both look about the same in terms of lots of lymphocytic infiltration. If you take a little bit of a closer look, you'll find that those lymphocytes have just run rampant everywhere in the iris. And here's what a normal iris looks like. Here's Star's iris. She was the abused racehorse. Now let's take a really close look at the ciliary body. This is a pretty high magnified view, and this is a very high magnified view. Remember how important it was for that ciliary body to be a soaker hose? This is like that tissue has just been smeared with butter. Okay, there's exudate all over the back of the stroma. And there's these interesting little inclusion bodies. Nobody really knows what those are, but they're very pathognomonic for all kinds of uveitis. And you get cyclitic membranes. You just get junk in the eye everywhere. And this is what things look like on high magnification. Here we are. Here's one of these follicles, just like Eurosport. You can spot it there, and there it is, just like a Peyer's patch. And here's a normal choroid and retina here. Here is Foxy. That's the pampered pet one. And she's got those, it's just like an army has moved in. And if you analyze these things, they have an organization too. They have B cells on the inside, T cells on the outside. It's amazing. And here's what's happening at the optic nerve head. Here's a normal optic nerve, retina. It's just gotten detached in the fixing. But here is Foxy. Here's the treasured pet one, full of lymphocytes. If you look down close, you'll see clusters, just like we've seen elsewhere, like those Peyer patches. And what does this practice data tell us? Well, it was a simple study following ERU cohorts over 11 years. There's messy data, but I think we really learned a lot from it. And I had the great experience of working with our local medical school, which has a very fine ophthalmology department, and was able to sort out some of the immunology of this. And so through that, we were able to increase the definition back 20 years ago of what the ERU immunopathology was. And we told the world our story, and it increased the awareness of ERU as an animal model of autoimmune disease induced by infection, which is a hot, hot topic. We found that about 60% of our ERU cases were linked to leptospirosis, and over 50% of the affected eyes were eventually blind. We also found out that it affected the pineal gland, the kind of a esoteric type piece of information, but maybe someday it'll come into play. And we demonstrated MHC class 2 expression on the resident cells. That was some of the high-end stuff. So what happens long term? I showed you what acute looks like. Just remember that ciliary body. All of a sudden, the trampoline springs are going to break. Your soaker hose is not going to be able to get the water through the hose. And you've got a lot of real estate, and the entire eye is depending on what that little creature is doing. So your domino effect is happening, and all this stuff that is inside the uveal tunic starts to get diseased. And it gets diseased in very many ways. What happened to the front in my 100 cases? 30 of them had corneal opacities, scars, stria, or streaks. 9 of them had that calcific keratopathy. Here's a very severe case. Usually it's not that severe, but it's still a real pain to deal with. 23 of them, this is really important, 23 of them, this is a take-home, suffered corneal ulcers at some point or another. Not because of lepto, probably, but because their eyes hurt, and they rubbed them on something. And you have to tell that client, yes, you have to have me come back and see your horse if it's flaring, because I don't know what's making it painful. We had, in the iris and the lens, 29 had posterior synechia. Remember that butter on the back of the iris? It's just stuck to the cornea, to the lens. And once it gets stuck to the lens and you get this whole diseased environment inside the eye, the lens turns cloudy. So 36 of them had a diffuse cataract. And they had, 23 had either iris atrophy or color change. And all these eyes look very different, but I think you're starting to understand why. It's just which way the dominoes fell. 7 of them had glaucoma. Now that seems a little bit not logical, because really an acute uveitis eye is like a flat tire. That ciliary body is not working. It's not producing very much aqueous, so it's very soft. So how do you get from that to the hard eye? Well, that's because the aqueous, once it gets produced, has to flow through the pupil on the other side of the iris and drain out the eye. And what have you got inside the eye? All kinds of junk and membranes and sticky stuff, and you just simply get a closed angle, and that precipitates that. Many, many horses had, this is a fallen down lens. The trampoline springs have broken, and I find that very, very common in Appaloosas. They must have weak fibers or something. 20 of them, 20%, eventually went tisical over that observation period. I enucleated 2 of them. I'm much quicker to enucleate these horses nowadays, though, because I really think a lot of them are suffering with chronic pain. 7 had blindness-related injuries. They ran into something. And 9 were put down. And I did, when I look back in my records, I did have notations that 7 of them were seen for a febrile illness in the months prior to the first attack. And again, the 2 mares, including the real valuable one that aborted, both of those were L. Pomona positive. So L. Pomona is linked to about 60% of ERU cases in a temperate eastern river valley. It often affects young horses. Some are bilateral, some are unilateral. And key take home, over 50% go blind. And so I think these eyes are starting to make a little bit more sense now, why they all look so different. Treatment, well, you can treat the symptoms. Can you really treat the disease? I don't think so, but you definitely want to treat the symptoms. You want to relieve what's going on in your acute flares. Atropine, this is nothing new to this room. Dexamethasone or prednisolone acetate. I tend to use dexamethasone because it comes in ointment type. And I would warn our owners not to use steroids without an exam because of that high incidence of corneal ulcers over the natural history of the disease. Systemic medicines, these horses hurt, and you want to cool down those eyes. Flunixin is the best medication to use. Phenylbutazone is also a very good medicine to use. Furocoxib, I haven't used it very much on uveitis horses. I'm using it right now on a fungal keratitis horse who can't have the other NSAIDs, and it's doing a reasonable job of keeping her comfortable. I think we probably need to use systemic medicines, medications a little bit more than we do, but we all know that those have their complications too. They're not going to control the disease, but I have taken to using them a little bit more recently. And you must taper off the dose because of all the complications. Antibiotics. People have thrown a ton of antibiotics at their lepto cases or just at their uveitis cases. Doxycycline, minocycline, tetracycline. And remember, the blood-ocular barrier is likely compromised, so even these things that don't normally get in the eye may be getting in the eye just fine. But almost everybody I've talked to has said it is very rare to really feel like you're getting any kind of a clinical response, but you're sort of desperate, so you do something. Colleagues who are board certified are using intravitreal genicin with some 4 milligrams, really, really dilute, like just a drop. This is not a technique for the average practitioner. If it goes wrong, it goes really wrong. But do understand that this might be a referral option. But still, you're just making things a little better. You're not curing anything. You've all heard about the suprachoroidal cyclosporin implants. Well, since those have been around about 10 years, we have learned that this is not the best treatment for the results have been disappointing in the proven lepto cases. It's still a very wonderful device to use to control intraocular inflammation, but probably not for these cases. And in Germany and in Central Europe, they do vitrectomies. There's a lot of complications with that surgical procedure, and it's very rarely done in this country because of the complications. So the bottom line is no treatment stops LAU recurrences or blindness. You may slow it down, you may have some beneficial effect, but I'm pretty powerless to help to prevent what is going to happen eventually. So the best strategy would certainly be to prevent leptospiral infection in the horse in the first place. And I'm not here to talk about the vaccine, but I do know that Zoetis has launched an equine vaccine recently. It is labeled to prevent leptospiruria and leptospiremia. No one knows if it will have any effect on equine recurrent uveitis or not, but there are lots of folks in the room from Zoetis who I'm sure are happy to answer your questions. Thank you very much.